actually is a big number for such cases. So basically it could be an optical indication such as a corneal scar, adherent glaucoma, or a failed graft, as you could see in these two pictures over here, or it could be a post high drop situation where scarring has taken place, could be therapeutic because of situations like this, or could be a tectonic or a cosmetic indication. I'll skip the surgical steps for now, but challenges, let's go to challenges directly. If you have any mass over here, like a pterygial mass or something, so you need to excise it like as you would do in a pterygium, because you don't want that vessel vascularization, whatever, to come and hamper these the clarity of the graft. If there's any conjunctival bleeding, then you can always do a cautery, or you can use, adrenally soaked gauze or cotton, and you can keep it there to control that part. If there is an intraoperative bleeding, ideally to avoid it, you should do a fine needle diathermy. It really does help. Otherwise, if it's here from the graft that's happening, so you can do these incisions in the periphery of the cornea to, direct the blood away from the center where you're working. Your field is clear then. There's a lot of, particularly in such cases, there are a lot of iridocorneal adhesions which you should expect. So therefore, if there are you need to be very gentle, careful, using two hands, using a rexus forceps or whatever you are comfortable with, and try to just gently peel them away from the undersurface of the cornea, because whatever iris that you save is going to help you in your result a lot. Sometimes, if it's a deep scar, it's okay to do a debulking also for a better visualization, and it really does help, because then you can have these controlled entry into the anterior chamber, and basically because then those adhesions that I was talking about, you can handle them a little bit better. The iris is torn, particularly a pupilloplasty is must in PK, particularly cases, because your outcome is not just your thing is not to just put the graft. You need to give vision to your patient. So pupilloplasty in such cases, whenever it is possible, is an absolute must, and it improves your vision quality a lot. Sorry. If there is any positive pressure, ideally you should be putting mannitol, should be given before, and if there is a lot of positive pressure, you can give the patient mannitol in the middle of the surgery as well. And usually, as you can see in the video, I loosen the speculum, and once that was done, as you can see right now, I'm losing the speculum, and it does help. And sometimes after the lens is taken out, there's a lot of positive pressure still, you can see in the video. So basically now I've just put the graft and switched to a temporal side because I can get a better view, and I've put the 4 sutures or 7 sutures, then I'm putting the IOL, and then basically I have increased the exposure from my speculum that was there. Sometimes it's not possible to put an IOL in an open sky because of this positive pressure. This is the dreaded ring, the complication that all of us don't want to have, and using a pharyngeal ring, although almost all of us are very lazy to put this ring, but it really can help maintain the globe. However, the outcome is extremely poor post if you develop a suprachoroidal hemorrhage. So if you have a case such as this is a subluxated PCIL, and this had a pre-existing PCR, as you can see in this over here. So then you need to do something about this. The capsule was trimmed, and vitrectomy, ideally you just cut that part, but you need to do an automated vitrectomy, which we had also done. The IOL needs to be explanted if it's not in the center, particularly if it's not in, so that, see this, as you can see, this IOL was broken. A vitrectomy automated, as I had said, was extremely important, and then you can put a 3-piece IOL in such cases into the center. Always do a good synecholysis because it's important, and then you can do pupilloplasty also after this. If in case such as this, if there is an if there's a aphakia case or a subluxated lens, you need to judge whether you need to keep the patient aphakic, or you want to do a secondary IOL or another IOL procedure at the same time. So as you can see over here in this video, it is quite the bag complex is quite adherent. A vitreous was there, so vitrectomy was done, and then this bag was removed, synecholysis was done, and then you can implant SFIL with whatever technique you are comfortable with, and I prefer to do in the same setting whenever it is possible. So post-operative challenges could always be the cataract formation that is always there. In fact, most cataracts develop within the first year, and it is more in indications of corneal scar, adherent glaucoma than with keratoconus and corneal dystrophy. And excessive steroid use and intraoperative manipulations are actually the major risk factors for cataract formation in PK according to this article. Astigmatism is always a challenge, and you need to use various modalities as you can see on the slide, but spectacles and contact lens and as suture management play an extremely critical role. Whenever there is cataract, you can always plan a toric IL later. So continuous suture adjustment can be done using an intraoperative keratoscope or using corneal topography, and you loosen the steep peridium and tighten the flat peridium till a circular reflex is seen, and less than 2 weeks is more effective. Interrupted suture or a selective suture removal is done later when the graft host junction is stable, that is 6 months, and you do generally 1 to 2 pairs at a time, assessment after 4 to 8 weeks. However, it's more predictable and the results are better when there's an agreement with the refractive, keratometric and the topographic axes. Whenever there are suture related issues like this, an infection or something, you need to take care of that, infiltrate, because that will also help. Glaucoma is always a problem for this, and you can put the patient on multiple AGMs, but sometimes a GDD is required. Graft rejection always is an issue over here, and it's DALC is always better if you can do it, and same thing with endothelial keratoplasty. Survival rate of PK has reported to be between 52 and 98.8% at 10-year follow-up. So it's extremely important. You need to keep your differentials in mind, and early recognition is extremely the key, and steroids have to be given. Special situations, particularly after failed grafts, they have an increased risk of failure as well as because of cumulative comorbidities such as glaucoma. And the failure rate, imagine, from 98% has dropped to around maximum of 70%, so 34 to 70%. So you need to control the IOP, inflammation. There are a lot of factors, and sometimes you need to do a P-hole transplant, is that small graft in the middle of that graft that was there. And interrupted sutures are always recommended because it's failed, and particular care and surgical planning, and you have to be prepared for a surprise always. So therapeutic PK, I've always felt it's more challenging than an optical one. Yes, optical you're giving vision, but you really don't know what's going to happen inside the eye. This is a couple of cases that we had done. This is courtesy of Dr. Nikunj, who's my friend and was working with me earlier, and you can see the results. This patient was lost due to follow-up. This is how we started with, and lockdown came and basically was lost, and this is how he was after 2.5 months, and then he was waiting for a cataract surgery. So this pediatric PK is another challenge, because the preoperative evaluation, and whenever it is there, it's quite difficult. Specialized in investigations such as UBM is always quite often required. IOP is difficult, and you need to watch out for systemic associations with the disease. As you can see the picture over here, this is a case of keratomalacia, bilateral keratomalacia, and this patient lost one eye because of late presentation. So there's less working space, there's a chance of severe hypotony, and thin sclera is there, so there's a risk of perforation. Feringa rings, when you put, they can have a difficulty while suturing, and you need to perform adjunctive procedures at the same time. Always be prepared for increased positive pressure, because in such eyes, and the cheese wiring can take place during suturing as well. Post-operatively, you need to evaluate the patient sometimes even weekly, and you need to remove the sutures. Ideally, suture removal is less than 6 months is around 3 months. For within 6 months, if the age is more than 6 months, but sometimes within a month also you have to remove the sutures. You have to keep a watch, and these require EUA. And amblyopia management with early visual rehabilitation is extremely important in such cases. This is an example of that keratomalacia case. This is another lady, another child that I had, lost to follow up, and parents were neglected, not at all caring. So you have to sometimes, I shouted at the parents, it's not recommended, but it was quite difficult, counseling them, telling them, please take care. So one graft was done, it was failed because they didn't put medications, and then again I repeated the keratoplasty. This is how she's aphakic, by the way, and but doing extremely well till I was seeing her. So to conclude, keratoplasty is extremely important, and you need to take care of a lot of factors associated with it, and special challenging situations as well. So thank you so much.
Thank you, Dr. Karan. So I'll have some of the questions for you. So first thing is, how you manage intraoperative high pressure when you open the button. So sometimes you see lens is clear, but still it's bulging out and it's not settling behind. So how to put the graft on that lens? So
what I would recommend is to give mannitol at the same time if it's possible. In some cases, what I have done is I have actually done a PPV at the same time. So just making an entry with an MVR going behind and just doing a vitrectomy at that area so that it decompresses that eye, and then you can do that. There are people who have actually used those Maligan rings and the B-hex rings also to keep that lens in place.
And in pediatric headache, how early we should take the pediatric PK cases? How early?
See, the thing is, if you shouldn't always take, if the other eye is normal, I would say no. Let's
still
keep
if
it.
both eyes are opaque, then how early you will intervene?
I would as early as possible, because the risk of amblyopia is always there.
Any comments, sir?
Yeah, I can normally prefer to take it around 6 to 8 weeks time. The thing is, the difference between that and taking it earlier than that is not very significant. And handling those smaller kids sometimes can be a challenge. So that's, as Karan said, that individual case, we take a call based on how much we can wait in those cases.
So if you risk of amblyopia is there in the initial 5-6 years, then we can manage those cases if we start therapy at 3 years or 2 years.
So if
why not to wait till 2 years?
The idea is that if you are able to delay a pediatric keratoplasty without losing anything on your side, I would certainly want to delay pediatric keratoplasty. So by doing any other methods, like by doing a optical iridectomy or by doing anything, if you're able to delay it, I would rather delay it. If you think that it's not going to help and you're losing time out, then I would go ahead and treat that.
Thank you, Karan. Thank you so much. So next talk will be by Dr. Yeah, please, sir, please.
The one thing that I wanted to say was that maybe in eyes that are phakic or where you expect that you'll have an additional vitreous procedure, flaring a ring is always useful, so that there is no collapse.
Yeah, that is very important.
And the other thing, that when you have that lens bulge, sometimes the cornea surgeon works alone, so you don't have, or maybe he's not versatile. So an MVR, sometimes an MVR requires a pressure that can actually cause the lens to bulge out more or even prolapse out. So you can take a number 11 blade and just cut through the sclera and just put in a say 26 gauge needle and aspirate out some of the vitreous. Of course, there's always a risk of causing a RD later on, but in therapeutic cases, like those are extreme cases where there will be a bulge. Just two conclusions.
Okay, thank you so much, sir, for your comments. So now the next talk will be by Dr. Himanshu Matalia, and sir will be speaking on DSEC in the era of DMEC, its significance.
Thank you, Bhupesh, and very good morning to everybody. With the long previous night, I'm really not sure anybody would have come, but that's really heartwarming to see at least few of us are here. When we talk about lamellar keratoplasty, one name pops up, and which is Garrett Millis. Millis, with his innovative self, has invented so many things for us, and I think thankfully to Millis that lamellar keratoplasty is alive and kicking, and in fact progressing. Whether it was DALK, whether it was DLEC, whether it was stripping of descemet membrane and then DMEC, it was Millis's idea which brought the entire revolution there. Why do an endothelial keratoplasty? Why can't we do PKP? As Karan was showing, that results are very good. Well, the advantage is faster visual rehabilitation, superior quality of vision, the trauma to the cornea does not rupture the graft, or an astigmatism wise, it's pretty decent. However, the disadvantage is that you can have its own different type of complications like donor dislocation or primary failure. It has its little small learning curve also. When we talk about DSEC, which I have to talk today, well, by DSEC we mean that it's descemet stripping, automated or manual endothelial keratoplasty. There are two main steps here. One is the donor preparation and second is the tissue insertion. So whatever we discuss, we split into these two steps here. Indication wise, we all know that the commonest indication is post-cataract surgery edema, whether it's pseudophakic or aphakic. Fuchs endothelial dystrophy, which was more common indication in West compared to our country, but well, it's catching up in our country too, because our cataract surgeons are becoming better day by day. Failed corneal graft, CHED eye syndrome, and post-endothelial decompensation due to endothelitis are the other causes. Now, when to choose DSEC over DMEC? Now, this boundary is getting blurred, and also it depends on the individual surgeons. Many surgeons who are prolific surgeons can actually handle many of these things, which I would say where DSEC can be done. But for rest of the mortal souls like us, we might want to reserve DSEC in some these kind of conditions. Like if the surgeon is inexperienced for DMEC, DSEC is a choice. A very young donor, DMEC sometimes behaves not so friendly. The donor graft does not open up and the scroll becomes very tight, and it can be quite frustrating. Sometimes very badly diabetic donor, or where you run out of your DMEC tissue, you already exhausted it by losing it, then possibly the DSEC would be the choice. The patient factor wise, poor visibility, or if you have a glaucoma shunt and you're not confident about getting a tight globe, aphakic or vitrectomized eye, large defect on the iris, and disorganized anterior segment, especially in TAS, I would swear by that I would prefer DSEC in TAS cases compared to DMEC, because the fibrin which comes into anterior chamber can be quite frustrating. The donor preparation can be either manual or it can be automated. I prefer automated for the obvious reason that it's reproducible and it's much more control. You can have pre-cut tissue also, or you can use femtosecond laser. Femtosecond laser is a very elegant technique, but cost factor is not something which is the best. And also there are possibility of endothelial damage in the periphery wherever the endothelium is fired upon from that side. However, I'll show you one of such case. Surgical technique wise, donor tissue insertion, when we talk about, either you can have techniques which are push-in techniques, or you can have technique which are pull-through techniques. So push-in technique can be Tacophold, which we all started with sheet glide, endosaver, many other such kind of techniques are there. Whereas pull-through techniques can be glides, something like Boson glide, tan endoglide, suture, and again. So every surgeon has their own whimsies and expertise, where each one of us can have something different, so whatever suits us is the technique which I would say is the proper technique. For the graft preparation, this is the automated graft preparation. So using an artificial anterior chamber, we first start the irrigation. So the bubble which is there in the anterior chamber escapes out. The idea of removing bubble is air is more compressible, and hence sometimes it can possibly give you false idea of tight chamber, but it can possibly a little smaller. After tightening it, loose epithelium is removed. I prefer to put a mark so that it's easier to replace the cap after cutting it. After doing the pachymetry, intraoperative pachymetry is something which I strongly believe is important. After doing a pachymetry, based on your requirement, you would put a blade, and on the wet surface, you would pass continuously. I normally count 1 to 5 in my mind, and 1, 2, 3, 4, 5, and you remove the tissue. After removing the cap, mark out the area of the cut so that you know when punching from the opposite side helps you. After marking the stroma and whatever, you can replace the cap. Now this step becomes very important when you dismount the tissue. So after starting the irrigation, when you dismount and when you lift it up, that's the place where it will go back and bounce it up. If you do not have the anterior cap, it may not bounce up, and it can have its own issues out there. After cutting this thing, you can use punch of your choice. This is a Hana's punch, which sometimes I use. You can use vacuum punch, or you can use whichever punch suits you. Vacuum punch, if you use, just remember that vacuum is going to generate on your cap, and your posterior graft can sometimes move on one side, but those spots which you made, 4 spots, helps you to center the graft properly. Coming to the technique wise, with the paucity of time, I'll try to show a couple of different steps and different videos. So now one such case of previous ACIOL vitrectomized eye, and the ACIOL was put inside, which was much smaller in size and was not stable. You can do the regular technique of your Descemet stripping either using air, using dispersive, cohesive viscoelastic, or sometime you can use your AC maintainer itself, and that works out. Whatever works in your hand is fine. Using air, you might have to keep entering the air multiple times. If using viscoelastic, well, it's much elegant, but you have to remove it completely. Whereas AC maintainer can possibly give you more stable anterior chamber. Disadvantage, AC maintainer flips away your Descemet continuously, so be careful. Now this graph was cut using a femto, so I had to separate out from the periphery, and here I'm using a tan endoglide. So again, another disadvantage of femto, but I didn't have access to my stroma there, so there was no possibility of staining there on the stroma. Now, this for the documentation that you can still stain, that's why I'm showing, but you do not need to stain now all the DSEC tissues. The tan endoglide is a pretty simple device where you can load it into a thumb drive kind of device. Under anti-chamber maintainer, you can pull in the graft using a forceps from opposite side. And the rest technique remains same. You can adjust your tissue later on. You can also have pull-through technique using something like Boosin glides. Now, Boosin glide again is very simple instrument, much cost-effective than tan endoglide. However, you can use tan endoglide again if you're careful, but I would say Boosin glides, it's simpler in that sense. Again, using an anterior chamber maintainer, you can keep the Boosin glide outside, pull in the graft, and rest everything remains same. You can take the push-in techniques where you're using sheet glide, put the tissue, put cohesive viscoelastic near the wound. You may not use even the glide, and you can actually put the dispersive viscoelastic like Helon next to your the wound, and use your either needle or Sinski to push the graft inside, float it, and DSEC can also be used for failed PKP. I think I've run out of my time, so I really don't think there's need to show the video here, but basically in PKP, you can take a little smaller graft than your graft force junction, do an ASOCT. You can insert your graft of whatever way you want to put inside, but make sure that you put your graft in a way that it stays in the center of your graft force junction. Being a little smaller, it will fit in properly and it will work. There can be all the potential complication with DSEC like dislocation and primary failure and those things. If it's a dislocation, you can use your air or gas to refloat the bubble. There are ways and means to reduce the chances of dislocation, and nowadays those things are much rarer. To conclude, DSEC can be better alternative to PKP in many cases. Proper case selections are mandatory. There may be a learning curve. Comparing DSEC versus DMEC, still there's a long way to go, and with your proficiency in the technique, well, possibly in future we will be doing more and more DMECs rather than DSECs. Thank you very much.
Thank you, sir. Thank you so much. I just have one question for you, sir. So what is your take on DSEC with ACIOL? How safe are they?
So that's the reason I showed that video, that I just wanted to make a statement that it's not as bad as we think. The ACIOL, we all have done such kind of cases. And this case, mind you, was done possibly 6-7 years back, and it's stable. There's no change in endothelial count. Does it mean that's my preferred technique? Of course not. I would like to fix it with either iris erythrofixation or scleral fixation, and then go ahead. Does it mean you cannot do ACL and DSEC? Is it criminal? It's not criminal. If anybody says that, I think that's not very scientific comment.
Thank you, sir. Thank you so much. So the next talk will be by Professor Rajesh Sinha, and sir will be speaking on anterior lamellar keratoplasty, past and present.
Thank you, Dr. Bhupesh, for having me in this course. I'll be talking about anterior lamellar keratoplasty, past and present. So past was all manual. Like we used to do donor dissection manually, we used to do host dissection manually, and it was, kind of anterior lamellar, so it was not descemetic kind of, and that is what we used to do in the past. But with time, what happened, that advancements came, and people started thinking about further ahead. Microkeratome came into practice, excimer laser came into practice, femtosecond laser came into practice, and that's how the protocol started changing. Now, the options started changing. People started thinking that we have to preserve whatever tissue is healthy, and we have to, sacrifice whatever is diseased. And so for very superficial opacities, we can do a PTK without, you just remove the superficial opacity and you can manage. But in further deeper down, you can go for a sutureless superficial anterior lamellar keratoplasty. So PTK is just use of excimer laser. You debride the epithelium, and for opacities or for any pathology extending up to 100 microns of the cornea, you can do it, because 50 to 60 microns you remove the epithelium, and the remaining you can ablate by excimer laser. So conditions like band-shaped keratopathy pre and post-op, you can see here, Rees-Buckler dystrophy pre and post, and post-pterygium surgery, which was encroaching onto the visual axis. You can have this residual opacity in the superficial stroma that can be cleared up by excimer laser. So that is something which can be done. But if the opacity is going further deeper down, in that case, you will have to do a sutureless anterior lamellar keratoplasty. The concept of sutureless anterior lamellar keratoplasty came into being because people, when in LASIK you have a free cap, you put the cap, put a bandage contact lens, and it stays like that. People started thinking that, even for superficial opacities, we can do that. And in a case of a Salzmann nodular degeneration with a cataract, something like that can easily be done. Any nodular keratopathy, trachomatis, any ocular surface disorder. So you can, once you remove the superficial haze, you can see how clear it has become. And then you can go ahead and complete the cataract procedure. And after completing the cataract procedure, just put a small air bubble and put the donor lenticule onto it, dry the edges, and then put a bandage contact lens. So the idea is that we can, without causing any astigmatism, we can remove the superficial haze and combine it with cataract surgery and provide a reasonably good visual rehabilitation. And this is a case of a granular dystrophy, which I showed, and this is the post-op picture looking absolutely fine. So again, a situation wherein post-LASIK epithelial ingrowth was there in the periphery, and this is the standard teaching that if there is an epithelial ingrowth in the periphery, then you should wait for some time before it comes to the center. You don't intervene. But then here what happened, that the clump of epithelial ingrowth formed, and it lifted the flap, and that caused flap melting. So you can remove, if in such a case you can just sacrifice the flap. You cannot keep the flap after removing the epithelial ingrowth. So you can sacrifice the flap and remove the epithelial ingrowth and put a bandage contact lens as well, and it will not cause that much of a refractive surprise. But if you can place a lenticule of the same thickness, nothing like it, if you have the facility for that. So, and you can know the depth of the flap, the thickness of the flap, previous flap, by anterior segment OCT, or by record of the patient how much LASIK flap was done. But ASOCT is a good tool wherein you can absolutely know how exactly it is done. So you put a tissue, dry it up at the edges, and then put a fibrin glue at the edge, and then put a bandage contact lens. Femtosecond laser has helped in this case because we used to find in few of the cases we had epithelial ingrowth in the periphery in these SAL cases. So people started doing femtosecond laser, using femtosecond laser for these superficial sutureless anterior lamellar keratoplasty. The advantage is that the edge is absolutely vertical, so the apposition is absolutely tight. So the chance of epithelial ingrowth is not there at all. I mean, it's absolutely negligible. This is a case of a healed keratitis, so there's some vascularization, but we could manage to do a dissection with the femtosecond laser, and then this patient was shifted to the main OR, and then the tissue was removed, and after that, a little bit of irregularity is there, which I try to smoothen it with the burr, and then donor lenticule has been placed, and the edge-to-edge apposition with by use of femtosecond laser is better than what we do with microkeratome. Then for further deeper down opacities, we can do an anterior lamellar, automated anterior lamellar keratoplasty, and this already has been shown the donor tissue dissection. I'll just show the host dissection, because as you can see, you have a very nice and smooth interface if you're using a microkeratome when you are doing automated anterior lamellar keratoplasty. So you can see here how nicely it clears up. Sometimes you have a thick scar, and more so in the periphery, but still some scar in the center. So you can do an automated lamellar keratoplasty, and you can see that the scar has almost thinned out. It has gone. So that is quite useful in providing good visual rehabilitation in these patients. And as I was mentioning, the interface is absolutely smooth. Another technique that is if you have a peripheral thinning, in such a case, tuck-in lamellar keratoplasty came into practice, and this not only provides a good refracting surface, and but also provided good tectonic support in the periphery. This was actually started by my mentor, Dr. Vajpayee at RP Center, and then we started doing it. And in many of the cases, we have found out that the results are quite good. You can see here good flattening in the center and good tectonic strength in the periphery. Deep anterior lamellar keratoplasty is something for the deeper opacities, and it's a case of a keratoconus wherein deep anterior lamellar keratoplasty is being done. So big bubble has been created, and then you reach the predesmatic space and then inject viscoelastic, and then further dissect the tissue and place a donor lenticule. Now, with the advent of the intraoperative OCT, it has really made life much easier. And a lot of modifications people are doing based on their own comfort, based on their own outcome. And in this particular case, what I'm trying to do, I'm doing first dissection in a case of a macular dystrophy. First layer has been removed, and then double bubble technique will be used. We'll inject a small air bubble in the anterior chamber, and then the big bubble will be formed. So you can see here the big bubble has been nicely formed, and thank you, and once you reach the predesmatic layer, then level, then you inject viscoelastic. You can see how well the desmase is falling posteriorly, and you are absolutely sure when you are doing dissection that the desmase is in the periphery. And then you can go ahead and dissect, you cut, and then this is a type 3 bubble, wherein both a big bubble as type 1 ahead of Dua's layer was there, and then another bubble was there behind the Dua's layer ahead of the desmase membrane. So after putting 4 sutures, I made a small puncture here to remove this air, and then further suturing was done. Another condition is that if you don't get a big bubble, then in that case you have to, sometimes you don't get the big bubble, you try but you don't get it, then you have to do a layer by layer dissection, and you reach up to the, almost close to desmase. Even if there are a few microns of stroma left, you can go ahead and complete the procedure. Another situation wherein you do layer by layer dissection is a case of a keratoconus with a healed hydrops, wherein again intraoperative OCT is quite useful in helping you to know at what level you are working and if there is any discrepancy in the stromal bed thickness that is left after dissection. So any ridge is there, so you can remove that. So intraoperative OCT that way is quite useful in order to smoothen the stromal bed so that you can place the donor lenticule nicely, and your interface is nice, not irregular, and you can have a nice visual outcome. So in conclusion, anterior laminar keratoplasty these days is becoming very popular. A lot of conditions wherein we used to do PK, it has been replaced by anterior laminar keratoplasty. If the pathology is less than 200 microns, then we can do sutureless, and if it's more than 200 microns, we can go ahead with an anterior laminar keratoplasty or DALC with sutures. Thank you very much.
Thank you so much, sir. It was a wonderful talk. And next talk will be by Dr. Rishi Swarup, and Dr. Rishi will be speaking on deep anterior laminar keratoplasty, bubble versus no bubble. I have a question for Dr. Rajesh.
Yeah.
Sir, in laminar keratoplasty, till how long you continue steroids in post-operative period?
See, in laminar keratoplasty, initially, of course, we start with the 4 times a day, then for a couple of months, and then after that we reduce it to 3 times, and up to 6 months we give 2 times a day, and then once a day low potency steroid. For it is variable. It can be depending upon the indications, whether it's whether we have removed the suture or not. Till the time there is a suture, I prefer a low potency steroid for almost 1 to 2 years time.
Like in full thickness?
Full thickness, I will give 1 drop throughout. But in anterior laminar keratoplasty, maybe 1 to 2 years. If I have removed the suture, the patient is absolutely fine.
How frequently you have seen rejections in these cases?
Very less often, actually. Very less often. And since the numbers are not that high vis-a-vis the cases that we have done, so as far as prevalence of rejection, etc., it is. We don't have our own data of that.
There is no standard guidelines, I think, on this.
Yeah, true.
That is tricky sometimes.
Yeah.
Thank you so much. Thank you so much, sir. So, Dr. Rishi, all yours.
Thank you, Dr. Bhupesh, for including me in this course. Dr. Rajesh has made my job easier, so I'll just skim through some of the things. So the topic given to me is bubble versus no bubble DALC. So as we all know, deep laminar keratoplasty is done when you have to kind of correct some stromal pathology, and you're dealing with a cornea which has a healthy endothelium. So ectasia, scars, and even certain infectious keratitis, you can get excellent outcomes with deep laminar keratoplasty. And because you're changing only the anterior layers, the problem of rejection is significantly reduced. It's not eliminated. And even if you do have rejections, they often can be treated medically, and you'll end up with a good outcome. So Professor Dua told us that there is the 6th layer, and that really has been a revelation. So in addition, in front of the desmase layer, you have this pre-desmase layer called the Dua's layer, and which is the plane at which you're trying to separate between the stroma and the deeper layers. Dr. Rajesh has already covered this, the use of anterior laminar keratoplasties for superficial. For deeper opacities or any other deeper pathologies, it's good to replace the entire stroma. And there are various techniques for deep laminar keratoplasty. It's important to plan properly to see if your patient is suitable and which technique will be good. And I think one of the very, very useful tools for planning of DALC is an OCT, an anterior segment OCT. It helps you understand what's happening in the deeper part of the stroma. And especially if you have some irregularities at the desmase Dua's area. Even if you have a scar which is adherent to that, then sometimes doing a desmetic dissection becomes risky and you have a higher chance of a perforation. So if you have to do a deep laminar keratoplasty in these cases, you would probably want to do a manual pre-desmetic kind of a technique. Topography, of course, to understand in ectasias, the extent of your disease, how much your cornea is thinned out, etc. So there are various techniques which have been described. The popular one is the big bubble technique introduced by Professor Anwar. There are several other techniques, and the reason there are so many techniques is because each technique has its own flaws, and basically it's a skill-dependent surgery. Femtosecond lasers are also used, but femtosecond lasers don't cut very well in the deep stroma, so they are more useful for fashioning the edge rather than the dissection itself. So big bubble technique has been alluded to in the previous talk. Basically what you're doing in this is you're injecting either air bubble or a viscoelastic bubble in the deep stroma, and basically that is opening up that potential space by finding its way, and you get basically a white ring of corneal emphysema with a central translucency. Once you've got that bubble will not go beyond 8.5 millimeters. So once you've got that bubble, you can take off a layer, or you can make this bubble also after taking out some stroma, and then basically you have to puncture the bubble like was shown like in this video. That's called a brave slash. To make this puncture safer, it's a good idea to put a little drop of viscoelastic so that the air escapes a little slowly. After that, you can put a viscoelastic in the interface. It's a good idea to put a cohesive viscoelastic. Otherwise, if you use dispersive, you'll have some particles in the interface which will cause a problem later. Then you can cut the pies of your stroma out using some sort of a scissor which is blunt tip. In this case, I'm just using a normal universal scissor, but there are specialized ALK scissors available. After that, you take a donor button, peel the descemes membrane off the endothelium, of the graft. Descemes membrane and the endothelium is taken off like this, and then you just put it on the bed which is dissected and suture it in place. Femtosecond lasers, like I said, are useful, but mainly they are useful to fashion the edge. You don't really do the dissection at a very deep plane by using the femtosecond laser. So for DALK, where you want to change more of the stroma, the mushroom configuration is the one which is preferred. So this is one such case in which we have done that kind of a mushroom dissection. This is the recipient, and you can see in the deep part of this thing, you can introduce your instruments to get your bubble. In this case, I'm doing a visco bubble. So once you got your bubble, you just, the steps are essentially the same. You cut across with a scissor and then remove your 4 quadrants. And then similar exact cut is there done in the donor, which you can separate on an artificial anterior chamber. And then because it's exact, the edges are exact matching, it fits like a manhole cover exactly in its place, and the position is a lot better. And of course then you suture it. Suturing for femtosecond edges is slightly different. So it's important that to understand this concept of type 1 versus type 2 bubble. Although you want this kind of a bubble in all your cases, sometimes you get a different bubble which is called a type 2, in which you get a water bubble like appearance, and that extends till the periphery. In fact, it comes from the periphery, and here you can see the outline. And this bubble is actually between the Duas layer and the descemes membrane, and in this kind of a bubble, the risk of perforation is a lot more. So why should one do manual DALK? You don't always get a bubble, and extreme ectasias, especially which go to the periphery, the big bubble doesn't extend to the peripheral cornea. High risk grafts where you don't want to have a perforation or a complication, you can go for it. And wherever there's a contraindication for a bubble, like in this case where there's a deep descemes irregularity after eye drops, etc. So traditionally we were doing these kind of cut and peel manual DALKs in which you do go layer by layer using a sharp instrument. But the problem with this is, because you're using a sharp instrument in the central cornea, you can have a perforation, and also your bed will be irregular, and you don't always get a descemetic dissection smoothly. Also, it's very skill dependent, and you can have low repeatability, and you basically need to use central sharp instrumentation, which can always be a problem. So we've used this technique called the groove and peel, in which you do a partial thickness trephination After that, we attempted a visco bubble, which didn't happen here, so I just decided to go ahead with this. And you use a scissor underneath your trephine edge, like is shown in this video. So you do a scissor dissection. We made a specialized scissor for this technique, which is available from Georgia. There's no financial interest. And then you kind of go all around and spiral deeper and deeper with each pass. And at some point, you'll start seeing the Duaz layer, which is much shinier and glassy. So you expose about 2-3 clockas of that. And once you've got a good exposure of that Duaz layer, the periphery, you see all this scissor dissection is all in the periphery. There's no dissection happening in the center. Then you just basically grasp that central edge and give counter traction with another forceps. And the entire stroma can be peeled off the Duaz layer using stretch forces, which are distributed over a large surface area, as you can see here. And it's a very repeatable technique. I've been doing it for many years now. And in my hands, this has now become my primary technique of DALC. And it really gives me very good optical and visual outcomes. You can see first postoperative day, the graft is absolutely clear and a smooth interface, as good as you would get in a big bubble DALC. This is a case of keratoglobus. In fact, this condition, the technique works really well because there's no attachments between the stroma and the Duaz layer. Just peels off like a LASIK flap. Therapeutic DALCs also, it works very well because the stroma is edematous and spongy. Again, peels off very nicely. This patient of therapeutic DALC, good outcome. So this is just another child who had stem cell deficiency along with a corneal scar and thinning, and we were able to give him a good outcome and save him from amblyopia. It's not that this technique does not have a chance of perforation. If you have deep scars which are adherent to the desmes, you can have a perforation, but most of the time these perforations can be managed if they are macroperforations with good outcomes. So DALC is the gold standard for isolated stromal disease. Both big bubble and manual DALC work very well, and I think it's important to understand the principles of various techniques of DALC, and you use the technique which you are comfortable with for an individual patient. You can also use a combination of techniques. If one fails, you can go to the other. Most complications can be managed in DALC, and even if you have a perforation, it doesn't mean you have to convert to a penetrating keratoplasty. Thank you.
Thank you, Dr. Rishi. It was a wonderful videos. And next talk will be by Dr. Praveen Krishna. And sir will be speaking on DMAC, the new warrior for endothelial disease. Dr. Rishi, I have a question for you. In your last slide, you have seen the management of perforation.
Yes.
So, is there any risk of double entire chamber when you?
Of course, there's always a risk, especially if you have a central perforation that can happen, or an inferior perforation. So it's a good idea to leave an air bubble if you've had a perforation. It's the first few days that you really need to be careful. And even if you do have a double anterior chamber, just go back and put an air bubble in the anterior chamber. Most of the times, you can solve it. Yeah.
Any use of any glue can be used?
No, I don't think glue will be a good idea to avoid a double anterior chamber. It can be helpful intraoperatively to seal your perforation to complete your dissection. But ultimately, that's not really going to seal it for too long. It will dissolve in some time, and if it has to happen, it will happen. Plus, it will leave a blob in the interface, which you may not want. So, if you just put a nice bubble of air, that's usually good enough.
And any use of gas in such situations?
You can use gas, but if you have a large perforation, maybe it may be a good idea. But I have never used, so air usually works very well.
Thank you, sir.
Yes. And then come back in the end. I've actually put a patch of stroma with glue to seal the perforation, completed the dissection, and then remove that later after putting the graft.
Thank you, sir. Thank you so much, Praveen, sir.
Thank you, Dr. Bhupesh, and some great talks already that you've heard in this session, and a really nice session from the perspective of the newer techniques in cornea. So my topic is going to be about DMAC surgery, and though I think it's impossible to actually teach DMAC in 10 minutes, what I thought I'll do is speak to you about why it is important to start thinking about doing DMAC and start converting to DMAC, at least in a few cases, if not all. Well, I've listed the reasons down here, but I'm going to go through them one by one about why DMEC is potentially a better surgery than DSEC is. So for all of you who've seen OCTs after DSEC surgery, you know that this is not exactly an anatomically more natural surgery. So you're taking off lesser tissue, but you're replacing more tissue, whereas in DMEC, what you take off is the desmoid and endothelium, and you replace the desmoid and endothelium, so actually it's much more anatomically natural. But probably the biggest reason why DMEC scores over DSEC is there is about an 8-fold reduction in the rate of rejection after DMEC surgery. And for this reason, even grafts that are high risk, say following post-penetrating keratoplasty, endothelial keratoplasty, DMEC probably is a better choice than doing DSEC if you can do the surgery, because it seems that these have greater longevity. Visual acuity as well, you'll see that a majority of patients after DMEC will actually be 20 by 20 with correction if they do not have any comorbidities. There are patients who go up to 2016. Now we've started doing DMEC with toric IOL, started doing DMEC even in patients who've had multifocal IOLs with great outcomes as well. This is not so for DSEC. The other advantage is the fact that you have a very predictable IOL power in DMEC. Following DSEC, you have about a 1.5 adapter of hyperopic shift, whereas in DMEC surgery, the average shift is only about 0.5, which is the reason why you can aim for emetropia or even for monovision following DMEC surgery. Visual recovery is also extremely quick and rapid following DMEC. So this is a patient who had PBK. This is pre-op pictures. This is on day 1. You can see a partial air bubble where the edema has already come down. And by day 3, you see that this patient already is seeing about 20/30, 20/40. So very rapid visual recovery, which is unlike any other keratoplasty procedure that we have in our armamentarium. Refractive predictability is the other important reason, because when you're trying to deliver your graft in DSEC surgery, the smallest incision that you can potentially make without hampering endothelium is about 4 to 4.5 millimeters, whereas in DMEC surgery, you actually can make an incision that is even smaller. Typical incisions in DMEC surgery are about 2.8 to 3 millimeters. There are injectors that go in through 2.2 as well, but may not exactly be the best idea. But the fact that this is similar to a cataract incision gives you greater control over the astigmatism that you will induce. There also are some differences in the surgical technique. The differences I'm going to point out very quickly. Like donor preparation, typically you do either a manual or a microkeratome dissection for DSEC surgery. Femtosecond laser is not used. In DMEC, nowadays in some eye banks in the US, you have pre-stripped rolls available. This is possible in India as well. And watch out for some news that you might be able to get pre-stripped DMEC rolls in the future as well. Donor prep in DMEC surgery is relatively simple, most of the time done by the surgeon himself in the operating room just before surgery. And this requires a little bit of skill, little bit of practice, but once you do about 5 to 10 cases, most of the times everybody can get a very successful desmoid membrane strip. This is just the process of creating the DM roll, and once you have the desmoid membrane completely stripped, it usually is very tenacious and doesn't tear or doesn't break very easily. The next difference in DSEC versus DMEC is the stripping of the desmoid membrane is not essential in DMEC, and even if it is done in a smaller area. Whereas in DMEC surgery, the stripping is very essential, because if you have overlap, then you will tend to have detachments, and the stripping usually is a larger area as compared to in DSEC surgery, because you do not want to have overlap between your graft as well as your host desmoid membrane. Incisions in DSEC surgery, they tend to be longer, and they also tend to make sure that they're self-sealing, because you want the graft to seal the incisions from the inside in DSEC. Whereas in DMEC, you do not want your graft to overlap your incisions. So in most cases, what you will be doing is very short stab incisions, so that they don't go into the area where your graft is overlapping your internal ostiums of your incisions. This is true for the main incision that you make, and this is typically slightly shorter than the incision that you will make after in cataract surgery as well. And so by default, most incisions are made temporarily to give you more space in the anterior chamber. Marking the graft is not essential in DSEC surgery because most of the time losing orientation is very difficult. But in DMEC surgery, usually orienting the graft or identifying the correct orientation is difficult. So I always mark my grafts with an alphabet. In this case, for obvious reasons, I put a P. And it is quite easy to identify the alphabet once it's in the anterior chamber. As you can see, after the bubble is put in place, you can see the P very nicely there to know that it is in the correct orientation. Sometimes in corneas that are not very clear, if you can't see how the graft is unfolding, the letter is your only recourse to be certain of the fact that the graft is opened up correctly. Loading and injecting the graft in DSEC surgery, usually the graft is loaded with the endothelium on the inside. This is showing a Busin glide loading with the endothelium being curled inside as you load and inject your graft. Whereas in DMEC surgery, you really do not have control over how the graft will scroll, but it is known that almost all grafts will scroll with the endothelium on the outside. So this is DSEC surgery, and you'll see that the endothelium is on the inside as you deliver it. Whereas in DMEC, the scrolls that form always have the endothelium on the outside, and with that knowledge, you can go in and start to unfold your graft as you inject it inside the eye. Delivery for DSEC, you have several systems that are available right now, but in DMEC, most proven delivery systems are using glass tubes. There's several manufacturers right now, some local, some international as well, and you can choose the one that is preferred depending on the technique that you would like to use. Manipulating the graft in DSEC surgery is also very easy because once you get the graft inside the eye, then all you have to do is hold the graft and move it around if it's not very well centered. But in DMEC surgery, you can't do that because if you hold the graft and try to center it, then you're going to tear the graft. So this is a case of DSEC where I'm actually going in and touching the graft, moving it around, washing the interface, and then putting an air bubble. But in DMEC, almost all manipulations of the graft will have to happen remotely. That is, you will have to learn the technique of tapping, where as you tap, the graft tends to open up, and you also need to be able to predict the direction in which the graft opens up as you tap, and also to make sure that you tap it in the correct orientation and the correct direction so that your graft opens up in the desirable manner. If you tap in the wrong place, it is possible that your graft will actually flow out of the eye, but if you tap in the right place, it actually opens up very easily. So no direct manipulation and mostly indirect manipulation. Attachment of the graft is quite simple in DSEC, whereas in DMEC, you'll need to make sure that you have an air bubble that is inside the eye for at least 24 hours. So to summarize the conversion of surgery from DSEC to DMEC, the reason why is probably primarily because you have lesser rejections, so you'll need to use lower amounts of steroids, potentially also better visual outcomes. There are some difficulties during transition, but on average of about 10 cases or so should be good for you to become a good DMEC surgeon. There are still some cases where you'd like to do DSEC where visibility is poor, if the patient has comorbidities, extensive peripheral anterior synechiae, poor posterior graft host junction, and where DMEC really will not give very good visual acuity. And the last slide that I'd like to leave you with is the fact that there are a few things that you have to unlearn when you're doing DMEC, unlike DSEC. To remember that DMEC grafts can tear, unlike DSEC. Avoid all direct contact with your DMEC graft because it actually is going to damage endothelium. Use fluid waves rather than touching the graft at any point of time. Center the graft before you actually start to attach because once you attach, you can't center it again. If there are folds, you need to detach the graft and then reattach it again, unlike like a LASIK flap. And air bubble management or learning how to use the air bubble is going to be really important to ensure that you have a predictable surgery. Thank you very much.
Thank you, sir. Thank you for the wonderful video of DMEC surgery. I just have a question for you, sir. In case of, what about the incidence of rebubbling in DSEC versus DMEC?
We looked at our series. The incidence in DMEC is slightly higher than DSEC. Incidence is about 5% or less is what we have. We use only air, we don't use SF6. 5% is pretty low, but we tell all patients that expect a rebubbling in case that you need to, and they're quite
and what could be the reason for this, for the higher incidence in DMEC?
Reason is because the tissue is naturally scrolled, whereas in DSEC you have the tissue that is the same curvature as your cornea, so it tends to attach, surface tension helps it, whereas in DMEC it's like a dog's tail. It tends to always scroll according to its original configuration.
Thank you, sir. Thank you so
Thank
much.
you.
And coming to the last talk of the session, that will be on femtosecond keratoplasty. We'll take just few more minutes. So I'll be speaking on femtosecond laser assisted keratoplasty. So it's well-known equipment that we use in daily practice and known as weapons of ophthalmologists. So it won't be wrong if we call them old weapon of ophthalmologists, as femtosecond has taken over all these instruments in our practice. So femtosecond lasers are doing everything from cataract to LASIK to keratoplasties. And femtosecond laser is a photo-disruptive infrared laser with a power of 10 to the power minus 15. So why we switch over to femtosecond keratoplasty? Whereas manual keratoplasty is a time-tested, most successful organ transplant, although it has some surgical challenges like problem of trephination, problem of ledge, the suturing technique, what is the correct technique, what is the correct tension of sutures, high astigmatism post-operatively, higher endothelial cell loss because of the handling the tissue, and slow visual rehabilitation. So to overcome all these situations, now we have femtosecond laser, which has the ability to perform incision of any angle at various depth within the corneal tissue. It permits full thickness graft with peripheral lamellar wound configuration. It works with a greater precision, finite control, and in an automated manner. It does minimal donor tissue manipulation and less endothelial cell loss. The main advantage of femtosecond laser is that in manual PK, the wound configuration is always vertical, whereas in femtosecond laser, you can create any type of edge like top hat, mushroom, zigzag, and any other configuration is possible. Because of this multiplanar configuration, the healing surface area is more, so the healing is faster in femtosecond laser assisted keratoplasty. So what kind of incision is best for which surgeries? For example, if it's a case of pseudoaphakic bullous keratopathy, top head shape is better because it removes less stromal tissue and more abnormal endothelial tissue, whereas mushroom shape is better because it removes more abnormal stromal tissue and saves more endothelial tissues, like in keratoconus cases. So there are studies that have compared the results of femtosecond laser versus manual keratoplasty, and they found that femtosecond is always better in terms of endothelial cell loss, less astigmatism, and faster recovery. So there are various platforms that gives the option of doing femtosecond laser keratoplasty, and right now we are using Femto Z8 from Zima. So this is one of the case done by femtosecond laser. You can see this is a case of dense corneal scar. So with the newer platform, you can penetrate the dense scars also. So after planating, the dissection is done, and this is a donor cut by femtosecond laser after removing the epithelium. The docking is done, and most of the time the cuts are very smooth, and with the intraoperative feature you can adjust your cut area, and just you have to peel the tissue. And the lens was implanted after removing the cataract, and the graft was placed. You can see the configuration, it just fit in the donor and the host. This is in the case of keratoconus. So advantage of femtosecond laser is that you have to put less sutures most of the time. 12 sutures are enough for all the cases of done by femtosecond laser surgery. See, the position is very nice on the table only, and there is no overriding or underriding of the graft. So this is a OCT imaging showing the host and donor position. It's very nicely seen here. So laminar keratoplasty is already covered by sir, and This is another case of recalcitrant epithelial ingrowth where we have done multiple times scrapings and all those maneuvers, and ultimately we have to do ALK for this case. So in such cases, OCT helps very well because you know the depth of the disease and proceed accordingly. So you can see this area, and the cut is done and surgery. So going to the next slide, and this is a post-operative picture of the same patient. You can see the donor and the host is nicely opposing each other without any interface scarring. This is another interesting case of central corneal disc scar where I performed hemi-automated lamellar keratoplasty because femtosecond doesn't penetrate with this scar. So what we did, we create a mushroom shape cut, donut shape, and we get a plane all around the scar. So this is a femtosecond plane. So now this scar will be dissected by manually, but with the help of this plane, the whole opacity is dissected in a single plane. So there is no chance of uneven surface post-operatively. And this is a donor dissection, and suturing is done. So this case also did well in post-operative period. So this is the last video that I'm showing. This is a femtosecond DAL. As Dr. Rishi told that it doesn't help too much in DAL cases, but with the new platform, we have the feature of creating a tunnel. So after the stromal dissection, you can create a tunnel, so you are sure your bubble will end up and you will get a big bubble in almost all cases. So that is the advantage of this machine. So this is a case. So after removing the anterior stroma, this is a tunnel created by the femtosecond laser, and you have to enter in this tunnel. And you can position the tunnel sizing, depth, and all those things, and then you have to enter with the formula cannula and just inject air.
Sir, I'm really sorry, sir. We are actually running out of time. We have run out of time.
Thank you.
Thanks
Thank
a
you
lot,
for
sir.
patiently waiting.
नहीं सेकंड नहीं मैं फर्स्ट ही हूँ जस्ट इंट्रोडक्शन बोलना है इंट्रोड्यूस कराना है लगा दो 1 मिनट